I'm really excited this morning to introduce our 13th CCC speaker today, Dr. Ben Cowling. Dr. Cowling is a professor and division head of the Division of Epidemiology and Biostatistics at the Hong Kong University School of Public Health. He's also the co-director of the WHO Collaborating Center for Infectious Disease Epidemiology and Control there, a fellow of the Royal Statistical Society, and a fellow of the UK Faculty of Public Health. He is really just an expert on infectious disease epidemiology broadly and has carried out groundbreaking work in the field. Specifically, he has pioneered, in my mind, the design and implementation of large field studies of respiratory transmission in the community and the effectiveness and impact of control measures. Some areas that I think his studies have had very large impact is identifying and designing studies to understand the modes of transmission of disease, airborne versus aerosol versus droplets, thinking about the effectiveness of hand hygiene, vaccine effectiveness, measuring the immunity to infections of individuals and at the population level, and then another aspect is the effectiveness of masks, of course. And I remember it was quite a long time ago that I saw Dr. Cowling give a talk with my favorite figure of all time, where how they measure actually the viral particles in aerosolized air. And there's, this picture of a person with his whole head in a cone, breathing and coughing. And one of my favorite figures of all time. And I think actually with COVID, it's been circulated quite a bit around the internet. And so recent focus, as many of you probably recognize his name, has been on COVID, and really, in my mind, has been kind of the go-to expert resource for a lot of early and current COVID dynamics. So he's done work on the early transmission dynamics in Wuhan, the temporal dynamics of viral shedding and transmissibility, the clinical severity of disease, thinking about face mask policies for COVID. And then today, I think we'll hear him discuss some super spreading. So with that, I'll let him take it away and really appreciate him being here.
Yeah, thank you. It's a very kind introduction. Can you see my slides okay?
Yep.
All right, thank you. So I'll just introduce myself and my group briefly, and then I'll just spend about 10 minutes talking about the situation with COVID in Hong Kong, control of the epidemic, and also super spreading. Hong Kong is a city of 7 million people located on the south coast of China. The view here is actually from the window just behind me. I have a very nice view of the city, and all the things you can see in the picture is the residences of about half the population of Hong Kong in Kowloon at the forefront, and then Hong Kong Island in the background. It's really a very, very dense city, and I think probably it would be the favorite place for COVID-19 to spread in the world. One of the favorite places for COVID-19 to spread, because people live on top of each other, is such a densely populated city, and really a lot of opportunities for transmission to occur. So I'll show you a reproductive number estimate later, which is pretty high. I went to Hong Kong in 2004, along with, on the left of this picture, Stephen Riley and Joseph Wu. Stephen went back to Imperial College, he's a professor there. Joe Wu is still here in Hong Kong. The guy highlighted in the middle is Gabriel Leung, who's now our Dean of Medicine, and I'm on the right-hand side. So this is more than 15 years ago, when the group was first formed. This is the entire School of Public Health with 4 people dedicated to work on infectious diseases. And over the following years, we built up more and more capacity for infectious diseases. So a few months ago, this was our team photo with our infectious disease research team, me and Joe in the front, and then a lot of other people now dedicated to working on infectious diseases. Actually, more people in this photo than in the previous photo, which was the entire School of Public Health. So we've really expanded a lot. Hong Kong's a great place to work on infectious diseases, great place to study respiratory infections like influenza and now COVID-19. We were one of the first places affected in January 2020, outside of mainland China. We had a number of cases identified in mid to late January. A little bit of local transmission, but not too much. Things really took off in Hong Kong with COVID-19 in March. which was triggered by imported infections from Europe, not mainland China, from Europe and a little bit from the US. And it caught us unawares because we'd done quite well until that point. There were a number of larger outbreaks, but we got the first wave under control. So on the left-hand side, our first wave had about 1,000 laboratory confirmed cases. Majority of those were actually imported, meaning they were people infected outside of Hong Kong, but then traveled to Hong Kong and detected as a case in Hong Kong. And then there was some local transmission. And on the right-hand side of this figure is our big second wave. And in between, we had a quiet period for probably 3 months almost, 2 to 3 months. Our second wave has been much bigger than our first wave. We've had so far 3,500 cases. The epidemic curve is definitely on the way down, but still have a way to go to get it back down to 0. And our objective in Hong Kong is going to be to get daily case numbers to 0 and then keep it there, preferably for longer than we did between the first and second wave. But that's not easy. Right now, we have a ban, a total ban on visitors to Hong Kong. So unfortunately, tourists are not welcome. And for Hong Kong residents who come back to Hong Kong from elsewhere, including mainland China, there's a mandatory 14-day quarantine, which is strictly enforced. So we really try hard to stop infections from getting in. And there's actually some loopholes in that policy. We have some special groups of people that do not have to follow the 14-day quarantine. And we think that's how the second wave got started, because of those loopholes, which are now being tightened up, some VIPs or whatever. So when we look at the first wave and try and figure out how we got on top of things, on the top part, sorry, it's a complicated slide. The top right part of this slide is a figure with the epidemic curve of the unlinked cases above and the linked cases, which are those cases maybe occurring in clusters, shown below the x-axis. And it's consistent with the previous slide where we had a peak of infections later in March. We didn't have a whole lot of local infections though. The bottom right-hand side of this slide is the reproductive number estimates, where reproductive number went up as high as 2 in mid-March and then came back down again and was successfully controlled. So we eliminated we stopped the epidemic, we controlled the epidemic. So this was our first wave. What was going on in that wave? So firstly, schools were closed all the way back to early February. They were never open in this entire period of time. We had very good test and trace going on since mid-February. We were doing a lot of lab testing even when we first heard about the infections in January. We picked up exported cases quite soon. I think we were one of the earliest places to pick up exported cases. And then we started testing all patients with pneumonia and then all patients with respiratory symptoms by mid to late February, and then going even broader. So we were testing thousands of people a day by the end of March. Anyone who's a confirmed case in Hong Kong gets isolated, even if they are an asymptomatic case. There's no home isolation for sick people. Every case is isolated until the doctors think that they're no longer contagious. Either they stop virus shedding, or in Hong Kong, they have the strange criteria. They could still be shedding virus by PCR, but if they have antibodies, detectable antibodies, then the doctors for some reason conclude they're no longer contagious and discharge them. But the concept is every case is isolated, even asymptomatic cases. We're also very good at contact tracing and quarantine. So we trace quite a number of contacts for every confirmed case. And then the family members, maybe the other very close contacts, will be quarantined in special facilities, holiday camps or hotels. Other maybe less high risk contacts would be asked to do home quarantine for 14 days. And that's monitored and enforced now. So throughout the whole period on the right-hand side of this slide, we were doing school closure, isolation of cases, good contact tracing and quarantine. And that wasn't enough to stop a community outbreak. What really stopped the outbreak is the yellow period. That's when the government asked civil servants to work at home and private businesses followed. So not only civil servants working from home, but many private businesses also changing to work from home. So we did some surveys. We estimated about half of the working population, actually changed to work at least part of the time from home. And we also, in the orange period on the very right-hand side of the slide, we also see an additional effect of the measures that were introduced in restaurants, bars, gyms, leisure centers, essentially closing many of those kind of facilities where transmission could occur. And for restaurants, allowing them to open, but with a capacity limit and with spacing requirements between tables, temperature checks on entry, etc. And one other thing, I think face masks are important, but face mask use was universal throughout the entire period on the right-hand slide. So we had 99% plus compliance with face masks in public transport, even on the street, in workplaces, high level of face mask use throughout, and it didn't prevent a community epidemic. I'm sure it would have been worse if we hadn't been wearing masks, but face masks were not enough.
Is there any general effort to encourage people to stay 6 feet or more apart in public? Sorry, can you hear me? Is there, in addition to face masking, is there distancing?
Yeah, so we don't have specific recommendations on the physical distance between people. There is advice to reduce crowding, but in Hong Kong it's difficult. It's really difficult. So working at home is a better solution because then people aren't even having the opportunity to see others. You know, the streets in Hong Kong are so crowded, it's almost impossible to have spacing between people in shopping areas, in other places. In restaurants, we do have a recommendation that tables should be at least 6 feet apart. But that's the only place that we have a specific distance recommendation. And I'm not sure that the distance is the critical thing, because I do think a lot of transmission is going on through aerosols, personally. So the distance wouldn't be critical. It would be the ventilation, the degree of crowding, and the duration of exposure would be as important as the actual distance between people. So one of the interesting phenomena that I want to talk about today is super spreading. We looked at clusters in the first wave, and we're now studying clusters in the second wave in Hong Kong as well, with very similar observations so far, but I'll just talk about the first wave here. So the slide here shows all the major clusters that occurred in our first wave, with about 400 local infections. And the biggest on the left was a cluster associated with bars, and a traveling band that played in a number of different bars. Monday night was one bar, Tuesday night a different bar, Wednesday night another bar again. And the band wasn't the same people every single night, but it was like a consortium, if you like. It was a group of musicians that played together. 3 of them played on one night, 4 of them on another night, and so on. And the outbreak linked to that band and the bars encompassed more than 100 people in total. The squares around these people indicate persons who were in quarantine at the point when they were identified as being a case, at the point when they had a PCR positive test. So if contact tracing and quarantine was essential to halt these kind of outbreaks, we'd probably expect to see boxes around all of the terminal nodes. But actually you can see many of the terminal nodes do not have boxes around them. So that's people who identified as cases in the community, many of them with other contacts that they could have infected and did not. So quarantine helped because you can see terminal nodes among people in quarantine, but in many cases was not necessary. So the left-hand side cluster is a bar and band cluster. The cluster B at the top middle is a wedding party cluster. Cluster C at the bottom is a cluster in a temple, a Buddhist temple in Hong Kong. And on the right are all the other linked cases, mostly family clusters and restaurant clusters. When we analyze these, we get serial interval data, of course, because we have links between the cases, and we get a serial interval like other estimates of 5 and a bit days. And actually, my colleagues and I published an interesting study looking at how serial interval distributions change over time as an epidemic becomes controlled. But I don't have time to talk about that paper today. But this serial interval is not too surprising. On the right-hand side of this slide, though, is the interesting thing. This is the super spreading part. So the offspring distribution is heavily skewed. And in our first wave, 70% of cases did not transmit infection to anyone else. And then at the bottom, 19% of our cases were responsible for 80% of transmission. And in our second wave is similar. So we see super spreading in the first wave, super spreading in the second wave. And it's kind of interesting. My feeling is that it should be like this elsewhere in the world, but perhaps not really recognized. So I'll say another way. I think super spreading of COVID is happening everywhere, but I think people maybe haven't realized that super spreading is happening everywhere. And so the consequence is many people with COVID are not that infectious. Self-isolation may not be critical, but some people with COVID are perhaps more contagious. And if they're given the opportunity to spread to lots of other people, for example, if they go to a bar, a busy restaurant, if they work in a busy office, if they have a job that brings them into contact with many, many other people, that's when you get super spreaders and super spreading events. And I know there's a push with terminology to describe super spreading events rather than super spreaders. But my personal opinion is that the person is also a key factor in a super spreading event. And sometimes these super spreading events are not single events. They could be like the singers we had in the bar. And so it was a number of super spreading events caused by a person or people who were super spreaders. And preventing super spreading is going to require preventing the opportunities for those events to occur, or identifying people maybe with high viral loads who could be potentially super spreaders. Let me just come on to the second wave then briefly. So our first wave was in March. We had a period of time with almost no local cases and then flare up at the end of June into July. I suspect we missed some cases in June because there were some community cases detected in early June out of nowhere, and we don't really understand where they came from. And we suspect there would be others that were not picked up, but maybe just sporadic. Transmission really took off at the end of July, and our highest estimate of the reproductive number is well above 4, which is quite a bit higher than we were expecting. We estimated in Wuhan at the beginning of the outbreak, before it was even recognized, the reproductive number was 2.2. Others have estimated a little bit higher than that, but we're getting 4 point something in Hong Kong at a time when we were still making an effort not to let too much spread go on. There were still some measures in place. So this is a kind of really rough slide. Sorry, I just drew it really quickly of what was going on at the beginning of our second wave. Life had kind of gone back to normal, except we were still having a very high usage of face masks, and we were still doing test and trace pretty well in June. So test and trace and face masks did not stop the second wave. What has brought it under control is all the social distancing measures that were added in towards the second half of July. The same things that worked in the first wave, basically. So our school closure, I'm not sure whether that was essential, but working from home, closing bars, nightclubs, cinemas, leisure facilities, gyms, etc., and having stricter requirements in restaurants. We've been tracking behaviors through population surveys, now doing it every week, phoning up, random digit dialing, asking about behaviors. And we see population behaviors tracking risk quite nicely, which is probably what we'd expect. So people saying that they would avoid going out, they'd avoid crowded places when there's a lot of community transmission, but relaxing when the case numbers are lower. And we're already seeing on the right-hand side of this figure some relaxation in behaviors in the past week or two. And then the face mask data, more than 99% of people wearing face masks in public since almost the beginning of COVID in Hong Kong. So we have universal masking all along. And people are pretty good at wearing their masks here as well. So we've had 2 community epidemics despite that. Brief comment on schools. We did have schools go back in June, probably the end of May through to July 10th. It was about 6 weeks in total. Schools required universal masking of everybody, no meals at school, because that would have been opportunities for people to take their masks off. So universal masking 100% of the time, no meals at school, seating in single file rather than in groups in tables, and no assemblies, no large group activities. In the 6-week period when schools were open, there were 15 confirmed cases in school-aged children. We think at least 12 of those had been to school during their infectious period, just before or around the time their symptoms began. Mass testing of schools identified no additional cases, so we infer that there was no, or at least very, very little within school transmission with the measures that were used in schools in Hong Kong. So that's school age in some in elementary school and some in high school.
And what does seating in a single file mean? I'm just trying to visualize.
It's like the old style classrooms where you just have columns of students sitting with spacing between the desks. And so it's different to the modern style where children sit in little groups around a table, like 4 or 5 people at one table, and then do group work.
Was there anything done with the ventilation?
Sorry?
Was anything done with ventilation in the school? So
it will vary a lot. It will vary a lot. Most schools would have mechanical ventilation rather than natural ventilation, but the ventilation rates would be widely varying. There would definitely be some schools with poor ventilation, but we don't know for this kind of analysis whether any of the 15 cases were in those kind of schools. That would be a concern to me, but just don't have enough information. This is just a very simple analysis, just to say that maybe schools are not too much of a problem, at least so far for us in Hong Kong.
One more question about schools. Did you also look at infection among teachers and staff in schools?
Yeah, so no infections in teachers, no infections in staff in the schools. There was one very small outbreak with a tuition center with a tutor and a couple of children. That was outside of school. That was like a cram school thing that, they go after school to do their homework. So there was an infection there, but not in school, not with teachers. And there was mass testing of these schools, including teachers as well, and no cases identified. So I'll come to the end. The take-home messages, face masks and test and trace are definitely important. They definitely do something, but those measures were not sufficient to stop spread in both epidemic waves. Hong Kong would have higher inherent transmissibility. That doesn't mean that those measures, maybe they could be sufficient elsewhere. Maybe they could be sufficient in Austin or Dallas, somewhere like, or Houston. I don't know, but in Hong Kong, not sufficient. We've seen a lot of transmission in restaurants, bars, and other places where there's lots of people gathering together, super spreading. And the measure that really helped us to get on top of transmission in Hong Kong was working at home and restaurant measures. And looking forwards, if we can get over this second wave, then we're going to try really hard to stop imported infections, because then life can go back to normal for 7 million people and relatively back to normal, while we wait for a third wave, which will occur sooner or later, but hopefully later. I think that's the same kind of thing. So maybe I'll finish there, Lauren. Thank you.